And so what we're looking at here is just me, and this would be clinically how I would often assess that IR-ER range. Gold standard would certainly be to use an objective measure, a goniometer or an inclinometer for sure. What we tend to find clinically is in our patient group, we're looking at quite big differences between these ranges. Very easy to eyeball it in most situations. And then obviously you've got that globally undercovered or shallow socket, and they often just have lots of range of motion in both directions. Now, as I said, as valuable and handy as this IR-ER range of motion assessment can be for these patients, there are lots of other structures, not just the hip bones, that can influence how much range of motion the hip has. This can be your joint capsule, your muscles and tendons, or hypermobility syndromes and conditions. So not something that is necessarily going to diagnose every single one of your patients, but surely a very valuable part of the objective assessment and your assessment overall. Now, Alicia talked about the acetabular versus femoral anteversion and retroversion. To completely diagnose that, and I touched on in the imaging section that we really need CT scan to confirm changes in femoral version. Our only clinical screening test that we really have is this Craig's test. So this Craig's test, what we're looking at is when is a patient when is their greater trochanter most lateral when you're taking their hip in and out of IR and ER in this extended position. So you can see me doing this in the video here. You want to palpate the greater trochanter. I fix the pelvis with my forearm, and I'm going in and out of IR and ER, determining when that patient's greater trochanter is most lateral. Normal would be, and you see me there on Phoebe, around 10 to 20 degrees of internal rotation. If somebody has less than 10 degrees, so maybe they're closer to 0, then you're looking at a patient that potentially has femoral retroversion. If somebody has more than 20 degrees of internal rotation, in terms of that's when their greater trochanter is most lateral, you're probably looking at some femoral anteversion. So this can be a really handy screening test just to try and think about differentiating between femoral and acetabular versions or differences. For example, if you think someone has a very anteverted or retroverted profile, but their AP pelvic X-ray is normal, this Craig's test is going to suggest to you, oh, actually, maybe the changes are in their femur, and that's why I'm not seeing anything in the acetabulum when you're looking at an X-ray.